Okay, welcome to this explainer. We are going to completely unravel the confusion around childhood tonsil issues today, separating the hard facts from the common myths. Now, if you're a parent, or really anyone who spends time around kids, you know for a fact that sore throats, loud snoring, and those awful restless nights are incredibly common. But knowing when a simple sore throat crosses the line into something that actually requires medical intervention, or, even surgery, can be incredibly stressful. It's confusing, right? Well, today, we're going to clear all of that up. We're going to look at exactly what these glands do, why they fail, and what the latest clinical guidelines tell us about how to actually solve these problems.
We've got a lot of ground to cover today, so we're going to follow a clear path. We'll hit 1. Meet the tonsils, 2. Tonsillitis versus strep throat, 3. Obstructive sleep apnea, 4. The Paradise criteria, and finally, 5. Tonsillectomy risks and recovery.
All right, let's jump right into Section 1, Meet the Tonsils.
To understand why things go wrong, we first have to understand what these parts of the body actually do. We hear the word tonsils all the time, but their actual biological function gets overlooked a lot. So the crucial point here is that these glands are essentially the body's immune gatekeepers. Everyone is born with tonsils, those two oval-shaped pads in the back of your mouth, and adenoids, which are made of similar tissue but are located higher up, right behind the nose. Because they're lymph tissue packed with white blood cells, their literal job is to physically trap bacteria and viruses entering through the mouth and nose. They take the hit so the rest of your body doesn't have to. But because they're constantly on the front lines, they're highly prone to becoming inflamed and infected themselves.
Which brings us right to Section 2, tonsillitis versus strep throat.
Let's clear up some major terminology confusion right now. People often use tonsillitis and strep throat as if they mean the exact same thing, but medically speaking, they absolutely do not. While strep throat is a specific bacterial type of tonsillitis, not all tonsillitis is strep throat. In fact, most tonsillitis is actually caused by viruses, like the common cold, the flu, or even the Epstein-Barr virus. Only about 15 to 30% of cases are bacterial. Strep throat, on the other hand, is caused by one very specific culprit, group A streptococcus. This distinction is absolutely massive. Why? Because if a kid has viral tonsillitis, antibiotics aren't going to do a thing. The treatment is just rest, hydration, and time. But if it's strep, antibiotics are totally necessary to clear the infection and prevent rare but super serious complications, like rheumatic fever.
Now, here's the tricky part. Even though the underlying causes are different, both viral and bacterial infections share the same miserable symptoms. A child might have red, swollen tonsils, tender lymph nodes, awful breath, and a fever. Because these symptoms overlap so heavily, you literally cannot just look at a child's throat and confidently diagnose the cause. This is exactly why proper medical testing, like a rapid strep swab in the clinic or a detailed throat culture, is absolutely vital. We want to make sure we aren't overprescribing antibiotics for something that's just a virus.
Moving right along to Section 3, Obstructive Sleep Apnea.
So, beyond infection, we also have to look at what happens when these glands grow so massively large that they create a mechanical roadblock. This is known as obstructive sleep apnea, or OSA, and let me tell you, it's a completely different battle than infection. During the night, parents might witness some pretty unsettling physical signs. When a child falls asleep, their muscle tone naturally relaxes. If they have significantly enlarged tonsils and adenoids, that relaxed tissue collapses inward and physically blocks their airway. Think of it like trying to breathe through a flimsy, collapsing straw. You might hear loud snoring, gasping, or even terrifying pauses in their breathing that last for several seconds. The brain registers the drop in oxygen, wakes the child up just enough to take a breath, and the cycle repeats. This leads to incredibly restless sleep. You'll see kids sleeping with their neck arched all the way back just to open the airway, or even a sudden onset of bedwetting.
But the daytime reality? It's a stark night and day difference. While adults with sleep apnea are usually just lethargic and sleepy during the day, childhood sleep apnea very often masks itself as behavioral issues. A child who is chronically sleep-deprived, from waking up hundreds of times a night just to breathe, won't necessarily act sleepy. Instead, they often act hyperactive, aggressive, or incredibly moody. They might struggle to focus in school or even be mistakenly labeled as having ADHD or being a slow learner, and it's all stemming from sheer neurological exhaustion.
We've seen just how miserable both the infections and the sleep obstructions can be. Which brings us to the ultimate question for concerned parents and doctors. At what point do we stop treating the symptoms and just remove the tonsils entirely?
That brings us to Section 4, the Paradise criteria.
To prevent unnecessary surgeries, the medical community relies on incredibly strict data-driven thresholds known as the Paradise criteria. This framework determines if tonsil removal is clinically justified, specifically for recurrent throat infections. Basically, doctors don't just guess anymore. It comes down to the numbers 7, 5, and 3. First up, 7. A child meets the criteria if they have had at least 7 fully documented episodes of severe throat infections in the past single year. And when we say documented, we mean a clinician actually recorded the infection, accompanied by things like a high fever, swollen neck glands, pus on the tonsils, or a positive strep test. The whole shebang.
Alternatively, we have the number 5. If the frequency is slightly lower, but more chronic, surgery is considered if the child has suffered from at least 5 documented episodes per year for the last 2 consecutive years.
Finally, 3. The threshold is met if the child endures at least 3 severe episodes per year over the span of the last 3 consecutive years. Now, if a child falls below these numbers, clinical guidelines strongly recommend watchful waiting. Why? Because the data shows the risks of surgery outweigh the benefits at that point. And honestly, most kids simply outgrow the infections.
And finally, Section 5, tonsillectomy risks and recovery.
If a child actually does meet those strict Paradise criteria, or if they have severe obstructive sleep apnea, we arrive at the shared solution: surgery. This procedure, known as an adenoid tonsillectomy, involves an ear, nose, and throat specialist surgically removing this tissue. It's often done as an outpatient surgery, meaning the child goes home the same day. But make no mistake, this is a serious operation. It requires general anesthesia and very, very careful post-operative management by the caregivers at home.
The recovery timeline is incredibly specific. The first few days are all about pain management, using medications and staying hydrated with things like popsicles. But parents need to be highly vigilant during days 5 through 10. This is actually a critical window because of the risk of secondary post-tonsillectomy hemorrhage. Essentially, this is when the surgical scabs in the back of the throat begin to naturally fall off, which can trigger bleeding. Most children make a completely full recovery somewhere between 7 to 14 days, but that middle week, it requires close attention.
Now, it's really important to note that surgery is not the only tool in the toolkit. For children who don't meet those strict surgical criteria, watchful waiting is incredibly common, simply because tonsil tissue naturally shrinks as a child hits puberty and their immune system matures. For sleep apnea, alternatives like CPAP machines, which gently blow air to keep the airway open at night, or steroid nasal sprays to reduce inflammation are highly effective. And for some older kids, healthy weight management can completely resolve obstructive breathing on its own.
But for those kids who truly need the surgery, the clinical evidence is clear and deeply encouraging. Removing the obstruction doesn't just stop the snoring. Because the child is finally getting deep, restorative sleep, it completely transforms their neurological development. The hyperactivity drops, focus returns, and their daytime behavior vastly improves. It is literally a night and day transformation for their quality of life.
As we wrap up this explainer, I really want to thank you for exploring this topic with me. We so often separate how we feel during the day from how we rest at night, but they are deeply intertwined.